Hi, and thank you for tuning into my discussion about obsessive compulsive disorder, or OCD. I'm going to tell you a bit about myself, and then we'll dive in. So just to explain, who I am and why I know a little bit about the topic. My name is Aiden. I'm a PhD student in clinical psychology at McGill University. My undergraduate education was also in psychology. I work as an intern therapist at the Emotional Health CBT clinic. So I do see clients and provide therapy. And my background in OCD is both sort of academic and clinical. I've personally treated several clients who do have OCD. And I've also worked as a research assistant in an intensive OCD treatment center, which provide services for those who have more severe OCD and maybe haven't responded to outpatient or less intensive treatment for their disorder. So the first part of the presentation is going to address what OCD is, and I have a second part which will talk about how we address OCD and how we try to help people who are experiencing it. So at sort of the basics of the bare minimum requirements for OCD involve obsessions and compulsions, as well as some level of impairment in one's occupational functioning or perhaps their social functioning. Oftentimes, multiple areas of individuals' lives are affected by OCD. It can also involve a great deal of distress related to having these obsessions and compulsions. So I'll just point out that it's possible to have a diagnosis of OCD with only obsessions or only compulsions. Most frequently, we will see that OCD involves both the obsessions and compulsions. And this is possibly a little bit controversial in the field. And the most typical presentation of OCD does involve both obsessions and compulsions, and often impairment and distress, but if you have one or the other, you can still receive a diagnosis. So sometimes the distinction between obsession and compulsion can be a bit confusing because they are related concepts. So an obsession is a recurrent and persistent thought, urge, image, or some combination of those. And it's experienced as intrusive. So the client does not want those images, thoughts, or urges to continue to happen, but they do. A compulsion, on the other hand, is a repetitive behavior or mental act. So we can see this as more active than the obsession. So involving some sort of action on the part of the client, whether that be an internal action and a mental activity or a physical behavior. The individual will feel driven to perform them. So it tends to feel as though they're losing their ability to choose to do these. And we can see that the compulsion will arise either in direct response to the obsession, or perhaps just to rigid rules that the individual has for themselves. So this obsession and compulsion relationship. So just to break it down a little bit more, so we see that obsessions are always internal, so they're always some sort of mental activity. They're often thematically related. So people experiencing obsessions will tend to have them related to some sort of topic. So perhaps related to contamination or to thoughts about accidentally harming their loved ones or something along those lines. And obsessions increase distress. So often anxiety, sometimes shame. And that sort of characterizes obsessions, whereas compulsions can be either internal, so some sort of mental activity, and I'll have some more examples of these as we go through the presentation, or compulsions can be behavioral. the compulsions are often related to the obsessions, sometimes logically or in a way that feels logical, and sometimes in a way that just sort of feels real to the client, even if you might not, as an outsider, sort of see the direct relationship. And compulsions are usually performed as an attempt to decrease distress. And I'll note that the phrase attempt to is important here because sometimes compulsions fail to decrease distress in the moment. And part of the reason that OCD tends to persist is because in the long term, compulsions rarely decrease distress. And I'll be discussing a little bit more about why that is as we move on and talk about treatment in the next section of the presentation. So some examples of how obsessions and compulsions might be related. So here we have an example of if someone's obsessions are related to the concern of being contaminated with the virus that causes COVID-19. We might see behaviors such as compulsive hand washing or compulsive sanitizing of one's hands or surfaces they interact with. If somebody is sort of plagued by obsessions related to sacrilegious images, maybe their compulsion might be to say a specific set number of prayers or perform some other religious rite in a rigid manner. And then sometimes we see this sort of magical thinking, which is what I was referring to when I said that the obsessions and compulsions may not seem logically related, although that it feels very much that way to the client. So if somebody has a concern about harm to their family, they may associate this with the need to flip a light switch until it feels right. And this can be a particular presentation that we'll see in this disorder. And we have 4 different subtypes of OCD. So these are, and I will go into more detail in the subsequent slides. So what's described here is more related to the content of the obsessions. So we have contamination, we have doubt about accidental harm, what's called just right OCD, and unacceptable or taboo thoughts. So the contamination and washing subtype is, I think, one of 2, along with the order and symmetry, just right OCD, which we'll discuss in a few slides, is probably one of the ones that people are more familiar with. So what we see is generally the content of obsessions are excessive worry about like microbial, maybe viruses, bacteria. It could be perhaps related to, for example, like we just discussed with COVID-19, or it could just be a general sense of contamination by any type of germ. And this is also often associated, first of all, with anxiety, as we see pretty much throughout OCD. And this also is often accompanied by intrusive feelings of disgust in relation to items, places, or people that the person suffering from OCD perceives as being contaminated. And then associated with that, we'll often see hand or body washing, sanitizing, and there's also often what can end up getting very complicated is this avoidance of cross-contamination. So if somebody washes their hands, then maybe they then feel like they can't touch their phone. So then if they touch their phone again, they need to wash their hands and then sanitize the phone. And it can sort of get into a cycle of anxiety and of avoidance. So this is this one presentation. Another subtype is the subtype related to accidental harm and checking behaviors. So the compulsions are related to checking. So this obsession or these obsessions will tend to concentrate on the notion that someone will accidentally hurt someone else, often without their knowledge or without them realizing. And sometimes there's concern that they might accidentally hurt themselves and not realize it. The compulsions related to this is where we often see many mental compulsions come into play. So we have mental review, so going sort of back through what a person did maybe in the day or in the last hour to like see like, was there a chance at some point that I could have hurt someone else. We'll see mental and physical checking. So as we see with the little image here, this obsession and compulsion subtype can often be exhibited in people being worried that perhaps they hit someone or something, like maybe a pet, while they were driving and didn't realize it and continued to drive. So sometimes we'll see people will, do a U-turn to go back and double check that they haven't actually hit anything. And then there can also be sort of like the mental checking, as mentioned, with reviewing what they did. Was there possibly a point where I could have maybe, like in this case, hit someone with my car or something along those lines. There's also often reassurance seeking. So double checking with people around them, like, oh, do you think, like if you're driving with someone, do you think that, like, do you think I hit someone? You think I didn't hit someone, right? And getting that reassurance. And then there's also just avoidance, because, for example, if you have this concern every time you drive, it might just be easier to not drive at all, because then you don't have to go through this anxiety. And of course, there can be, other examples of this subtype of OCD that don't involve driving. So maybe a new mother might have obsessions about accidentally, harming her baby in some way without realizing it, and have to continuously, check on her infant every few minutes. So there's a lot of different sort of specific presentations, but generally the theme is related to worrying that you've accidentally hurt someone and ways to try and confirm to yourself that you did not. This just right OCD is, as I mentioned, related to order and symmetry, and is maybe the other sort of pop culture, more familiar example of OCD. So this involves the persistent sense that something is either not right or incomplete. And this is sort of described as more of an internal feeling. So there's this sort of feeling of discomfort or tension that comes up for the client when things are not just right. And this can lead to compulsions. This can often be where we will see sort of magical thinking, that we can see that there might be a certain way that things need to be organized in order to set this feeling right. We also see often, ordering, arranging, symmetry, maybe rituals related to counting, different repetitive behaviors, checking behaviors. So counting will often be a thing that a certain number will feel just right. So for example, someone might be interested in multiples of 3. So maybe they have to unlock their door 3 times for it to feel right. And then they need to wash their hands 9 times every time they wash their hands for it to feel right and complete. So this is sort of more, it's intrusive and anxiety provoking, but it's more related to this just sort of a nagging feeling of discomfort, less so with the other subtypes where we might see more like disgust, as mentioned with contamination, or really high anxiety is related with doubt about harming someone else. And then lastly, we also see these unacceptable or taboo thoughts and mental compulsions that are related to those. So often in this case, people will have intrusive and disturbing thoughts that are related to things that are really uncomfortable to the person. So these often include sexual themes, ideas of aggression or violence towards others, and if in people who maybe are more religious, it often includes sort of like sacrilegious images or urges or thoughts. And what we might see, for example, often one thing that comes up is people have anxiety related to being a pedophile, and are sort of plagued with these thoughts of like, what if I was a pedophile? What if I was attracted to children? And they're not. They're in fact very unlikely to ever be sort of in have those actual urges because it is so disturbing to them. But they're sort of plagued by these concerns about that. And this is sometimes seen as what's called pure O or pure obsessional OCD. And this is a bit controversial in the field among people who study OCD, but typically at this point, and that might change in the future as we learn more about OCD, but generally what's thought is that it appears to be a purely obsessional OCD, but people are often performing covert compulsion. So that's again something internal. So perhaps they are engaging in, mental checking, mentally, going over things in their mind, or reassurance seeking, which is not so much not so much covert. So this is maybe an area that might, our scientific understanding of it might continue to change in the coming years. But typically this is seen to involve a lot of mental compulsions. So often people wonder why OCD develops. It's a very unique kind of experience. And the fact is, as with what will be the answer for most psychological disorders, is that we don't have one answer. It's very rare. It's very rare even with medical, like more physical medical disorders, that there will be one single factor that plays a role. So we believe that genetic, neurobiological, behavioral, cognitive, and environmental factors all likely play a role. And OCD is a disorder that still requires research. There are still a lot of questions that we have, as I was just sort of alluding to when I was discussing this notion of the pure OCD and whether or not that really exists. So ideally, as we move forward, we might be able to better understand the things that underlie OCD. One thing that we do see, as I mentioned, there are cognitive factors that that are common in OCD, and we tend to see these different thinking patterns or thinking tendencies in people who have OCD. So we have an inflated sense of responsibility. So just feeling that someone is more responsible for, it could be the safety of people around them, or just sort of taking care of things in general, that we see that is more or elevated in people with OCD compared to those without OCD. There's the overimportance of thoughts. So this means that often people with OCD will equate having a thought of something to actually doing something at a rate that we see more often than in people without OCD. So if somebody, for example, has those taboo thoughts, if somebody has a thought about murdering their mother, obviously it's a very distressing thought, a very distressing image to have in your mind. But we will see that people with OCD maybe consider this almost like as morally equivalent to actually doing that action. We also see that people with OCD tend to want to control their thoughts, which can end up being a bit of a losing battle, since OCD is, marked by these intrusive thoughts, and thoughts generally are not controllable. So that's actually a suggestion as to why people with OCD maybe do get fixated on these different obsessions that they have. And the suggestion there is that everyone sort of has intrusive thoughts, but most people can say, oh, that was weird, and move on. Whereas someone with OCD starts to fixate on that thought and think, well, why did I have that? Why did that, intrude into my thinking? Why can't I control this? I must be, a bad person, that sort of thing. People with OCD tend to overestimate threats, so they see situations as more harmful than they typically are. We see a lot of perfectionism in people with OCD, and also the intolerance of uncertainty. So the idea of uncertain outcomes are very uncomfortable for people with OCD. And this is the end of the first section of my presentation. So hopefully you will stick around to learn exactly how we treat OCD, which is in my next set of slides. So thank you for tuning in, and I will be available for questions after this presentation.